All right, we're going into Chapter 14, Psychological Disorders. If you want to learn more about Chapter 14, then it is Psych 260, otherwise known as Abnormal Psychology. All right, so first we have to understand that there are a whole lot of stereotypes that go along with mental illnesses. And typically those stereotypes through media, through movies, through whatever we tend to take in around us, shows that anyone with a mental illness must be evil, threatening, or prone to violence. It doesn't typically show them in any type of good light or positive light. So, of course, we've tried to fight against those stereotypical thought processes that are out there. You may have seen billboards that say, "I am not my mental illness," and it'll tell you what they are, what they do, things that they enjoy, to show that mental illness does not mean evil, threatening, and prone to violence. All right, when it comes to psychological disorders, the first thing that you need to know is, of course, our definition. It's a dysfunction in your cognitions, which is your thought processes, emotions, or behaviors. There's three main things that I have here. The first thing is that it must maintain a maladaptive behavior, which means that it interferes with your daily living skills. It interferes with things that you want to do, things that you used to do. Family members will notice that it interferes even if the person who has the psychological disorder does not. The other thing that's a big one is distress. Does it cause that individual distress because they have the mental illness or disorder? Or can it cause others distress? Now, when we get into the personality disorders, that'll be a subsection that is really big in them not having distress from their mental disorder or feeling stress from their mental disorder, but others around them do. And then we have to look at what our DSM-5, our Diagnostic and Statistical Manual, states. And it's going to be any kind of disturbance in the psychological, biological, or developmental processes that underlie your mental functioning. Now we're going to go through an example. So we're going to hit attention deficit hyperactivity disorder again later. But what I want to show to you is what's called the 4Ds. Now there's only 3 listed here, and I'll explain why, but 4Ds. So how do we go about diagnosing somebody with these 4Ds? So for example, most people know or have heard of when they come through classes ADD or ADHD. So it is the inability to focus, they tend to be disorganized, distractible, all those good kind of things. And now when we're looking at an individual, we have to look at the first D, which is deviant. So is their behavior different than everybody else at their age, in that class, whatever it is surrounding them? So I get many students that'll say, I was really ticked because my teacher told my parents that I had ADD. Well, what gives that teacher the ability to say that you're deviant? Because that teacher of anybody will know and recognize that your behavior was extremely different than the rest of the 30 students that was in that class. So either you were overly excited, overly anxious, unable to focus, unable to pay attention when the other students could. Your level of maturity was less than the students surrounding you. How deviant was your behavior will decide. The unfortunate thing here is that we do have a difference between boys and girls. We do find that more boys get the diagnosis of attention deficit hyperactivity disorder, and the reason is they act out more. Boys act out more in the first place. So to have this means that their acting out is far more extreme. On the other hand, girls, we find, tend to be attention deficit disorder without the hyperactivity. And so they'll tend to be the wallflowers, as we used to call them. They're real quiet. They don't interact. They just seem to be hidden in the world. Then we have distressful. Does it cause yourself or other people distress? Now, what I find with many students with ADD or ADHD is that they work very, very hard. They try their hardest, but they are unable to remember or understand or get the information that everybody else does. So they try their hardest and they never get that A. They're always at the C range, or they're always getting in trouble even though that they think that they were behaving. So of course it causes them distress. Now, can it cause other people distress? Well, imagine that instructor that has 30 students and this one student is constantly consuming their time so that the other 29, although they need attention too, are not as deviant in their behavior, so it doesn't consume their time all the time. And then is there dysfunction? Dysfunction means that it interferes with your relationships, it interferes with your grades, it interferes with normal behavior. So, again, you work your hardest all the time, never get there. The dysfunction is that even though you're working at your maximum capacity that your brain is allowing, how come you're never achieving those goals that you want to get to? Relationships is a big one. What we find is that students surrounding those with ADD or ADHD find that they have a hard time taking a turn. It's always their turn. They find that they get hurt more often because they're playing with those individuals because they're more spontaneous, more restless, more agitated. So they tend to walk away from those relationships or not hang out with those people as much. When it comes to the ADD, of course, there's relationship interference because they're afraid to talk to other people. And so the other students will think that they're stuck up. But they're not stuck up. It's just that they don't know even how to interact or how to even try to get involved. So does it impact relationships? And it's absolutely. Then we have the fourth D that you can add, and that's dangerousness. So when it comes to being dangerous, is an ADD or ADHD individual dangerous? Well, here's the way it's evaluated. It doesn't mean that you're going to go out and start killing people. What it does mean, though, is that when you're playing kickball and that ball rolls across the road, and other people your age will stop at the road and look both ways before going for the ball, will the ADD or ADHD person just go and get the ball without looking both ways? And is that dangerous? Of course it is. So there's 4 Ds that you have to look at and that we use to evaluate, and the fourth one is dangerousness. Understanding the nature of psychological disorders, we actually have to look at our past. Now, we've discussed this before in earlier chapters, and our past was that it was not run by those that were psychologists, psychiatrists, biologists, or anything else. It was run by churches, and churches said that anybody who had different behavior than what they deemed as normal were possessed by demons, were evil was taking control of their body and their mind. And so, of course, the main ways to cure that were through approaches to get rid of those evil spirits, which could be trephining, which is what that's called right there. You may have heard of it as a lobotomy, but a lobotomy goes in through the eye. Trephining is opening the skull area to let that evil spirit out. Now, many times, of course, if you've had any damage to your brain, you'll know that it expands. So this would expand, and your brain would start to come out of those holes. And they would believe that that was the evil spirit coming out, and then they'd just slice that piece of brain right off. So, of course, many times it would kill patients off. Many of the other things would kill patients off as well. There was spinning them until they not only vomited and defecated, which is going poo all over themselves, but then until the point that blood was emitting from every orifice or every hole that you had, which of course is not good for you. Spinning people will also cause their brain to swell, which means they bleed out their eyes, their nose, their mouth, their ears. Of course, that was the thought process back then, that the evil spirit was coming out by doing that, but instead it was causing harm. Now, they did it for moral and ethical reasons. They thought they were doing the best thing that they could. And they did not recognize that what they were doing was actually causing more damage, because after doing it, that individual would remain calm, would be in a more vegetative state. And because of that, they thought that they had had success. But after your brain starts to heal itself, they found that the behaviors began again, and if not, got worse. So then they'd try something different. They'd try another way. Now, the beatings that happened to be more along the whipping line, and they would have massive whips that would tear every inch of skin you had, in between your fingers, your toes, your buttocks. Everywhere that there was skin needed to be torn open. And the reason it needed to be torn open was so that those evil spirits had a chance to get out. Now, again, if you were beaten like that, then you would be quiet. Your body takes time to heal, and then behaviors would get worse again. Now, a guy came around, and his name was Penal, and Penal came around and said, all right, instead of thinking it's demonic possessions, let's start saying it's more about stresses that are related to that individual, brain issues, and inhumane conditions, and start to treat them more on a moral level. Now, his moral level was the best moral level that they knew at the time. Again, not the greatest. What we look at back then for moral treatment, we'd go, oh my God, that's not moral treatment at all. But it was better than what they were getting. So we have come a long way, and we still have a long way to go. Now we look at it with a medical model, and the medical model is just like a doctor's approach to a medical disorder, and it is that it's a psychopathology, which means that's an illness of the mind that must be diagnosed based off your symptoms and has to be treated in some way, shape, or form, which tends to be a version of therapy. Of course, everything we look at is the biopsychosocial approach, and here's examples of biological, psychological, and sociocultural influences that can cause psychopathological issues, otherwise known as mental illnesses. Many of our mental illnesses are culture-bound. Culture-bound syndromes means that it stays and seems to be mainly in certain cultures. So we know that depression and schizophrenia are in every culture, no matter what it is. But some examples of culture-bound syndromes. In the United States, we have an issue with the eating disorder bulimia nervosa. And that's where they eat a great deal and then they throw it up or try to get rid of it in some other way. You may have heard of it as binge and purge. Now, that's mainly a United States gig that is starting to move out to other countries, but anorexia, where we see in other countries a great deal, we see bulimia here as a United States thing. Running amok is in Malaysia. That's with violent outbursts. Hikikomori is a social withdrawal, almost like in the United States a hermit, what we would call a hermit. We'll discuss those in personality disorders. And of course, there's more definitions that go along with hikikomori for their type of social withdrawal that works just in Japan. How is it that we diagnose? We actually have a medical type book, and it is the Diagnostic and Statistical Manual of Mental Disorders. The newest edition right now is the 5th edition. There's many more before that. We find that it takes years to figure out whether it can go into that Diagnostic and Statistical Manual based off of lots of research, and then it takes lots of research to get one out if it is incorrect. Now, when we look at the commonality of psychological disorders, I want you to look at where the United States is compared to every other place that I have on this list. Now, when it comes to any mental disorder or serious mental disorders, we're number one. Now, typically I do a discussion on why you think we're number one, and people would come up with lots of reasons as to why, and none of them would actually work. The main reason we have the number one a prevalence of psychological disorders has to do with the fact that we don't have universal health care. So what we have is people that are unable to afford to go in when they figure out that they might have a mental disorder. We don't take care of those that do have significant mental disorders that cannot take care for themselves or others. So that lack of health care causes not only one mental disorder to happen, but then it can go into many mental disorders. Once we've opened that door for one, we find that it moves to two, then it moves to three, and it keeps on going until there isn't a control and it's become a severe issue. So we have to look at the fact that until we start to care for individuals that need that help, it's just going to be prevalent and continue to be more prevalent than anywhere else in the world. Now, one of the things that causes our mental disorders in the United States that also puts us more at risk than other countries has to do with poverty. Now, many will think, well, wait a minute, there's other countries that have poverty, and there's other countries, the underdeveloped countries, that it's all poverty. Well, here's the difference. Poverty causes mental illness when you can truly see a huge difference between the haves and the have-nots, which causes more stress, which causes more mental illnesses and physical illnesses, by the way. In an underdeveloped country, they're all poverty stricken, so there isn't these huge haves compared to have-nots. It is so significant that we have something called the immigrant paradox, which means that an immigrant coming to the United States has less mental illnesses and less stressors amongst those mental illnesses, so that there's a significant difference between those that are born in the United States and those that come to the United States. So the United States has a significant issue with the fact that we don't care for those that need the care. And then we have the huge difference between the haves and the have-nots, which causes a larger problem. Now, the ages of vulnerability you can read on your own, but each and every one of them, a lot of our disorders that we have will have averages of onset, which means we know approximately when they can begin. First disorders we're going to go over is called mood disorders. Now, we're not going over all of them. Abnormal Psych goes over them more in depth, but there's so many disorders out there that we can't actually talk about all of them, even in abnormal psychology. And we're just going to touch on a couple of things when it comes to this class because it's only covered in one chapter. So the things that our chapter covers is major depressive disorder. Major depressive disorder and its diagnosis. Now, that's depression, and this is one of the most significant depressions that we have out there. It's feeling empty, it's feeling vulnerable, it's not just feeling sad, there's anger as well in there. There's emptiness, feeling alone while you're with other people, the inability to get out of bed, feeling tired all the time but not able to fall asleep. There's lots of things that surround that major depressive disorder as far as symptoms. And then the other mood disorder that we have is bipolar disorder. You may have heard of it as manic depressive disorder. Now, when it comes to bipolar disorder, they have not only the major depressive disorder or the lowest levels of depression, but then they have sheer and utter euphoria at the other end. And that manic or euphoric, best in the world, joyous type of can't do anything wrong feeling is an extreme that can cause them all four of those 4Ds as well. Now, I always get asked, can you just have the manic version of bipolar disorder? And the answer is no. So there is no just mania. That tends to lie, if you have symptoms that you think is manic, then that'll lie in some other area, and some of those we'll hit on today. Now, both mood disorders, whether it's depression or whether it's bipolar disorder, are genetically linked. So you can have a predisposition towards having these disorders. Look at your parents, look at your grandparents. Is there bipolar disorder or any kind of depression in your history? If there is, then you can have a higher likelihood of it taking place for you. That does not mean that it'll automatically take place. It just means that you should know what the symptoms are of those things so that you can recognize them better when they occur and be able to take care of them and get some help by being able to recognize them. So if there's a pregenetic disposition, get to know and understand what those things are so that you can recognize them easier so that you can take care of them before they go too far or take full effect. Now also when it comes to the genetics of it, it takes a lot of markers. It's not like one gene that comes down and says, all right, this is the way it is. It can be 18 different genes that have to intermingle with each other, that have to be handed down. It can be 32 genes that have to be handed down. So there's quite a few different markers that have to come together. But if there's a history of it, those markers have a higher likelihood of coming down. So let's look at the way the DSM looks at major depressive disorder and how we would look at it to diagnose it. All right, so major depressive disorder. The first thing that we're going to do in our diagnostic and statistical manual is say, all right, there's symptoms of depression. So we look under the depression section, and there's a whole bunch of different types of depression. So how is it that we diagnose major depressive disorder compared to SAD, compared to any other version of depression? And the first thing that it'll say is in bold, they'll be bold, and the top two, some of them will have even 3 of them or 4 of them, but the top 2 in this one, you must have one or the other. If you're not depressed mood most of the day or markedly diminished interest or pleasure in activities, then it's not major depressive disorder. We got to move on to the next one. So you must have one or the other of those two, if not both of them. Then you can look at this one. And then, in addition to those 1 or 2 top ones, you must have 3 or more of the other symptoms. Again, if you don't have 3 or more of the other symptoms, we move on to the next version of depression. Now, hopefully you get somebody that is well-known enough, well-read enough, that they have their diagnostic and statistical manual memorized just as much as your doctor or physician does when you go to them. But if you've ever seen a doctor or physician look up something online or look in a book or say, just a second, I'll be back, I need to look into this, what they're looking at is their diagnostic and statistical manual to find what you have based off of your symptoms. And that's the same thing that we would do. Now, I typically bring in seasonal affective disorder because it's something that happens to us around here. So seasonal affective disorder we also know of as SAD, S-A-D. Now, why does that happen around here? And why does it happen more often to women than it does to men? Well, for one reason, it has to do with vitamin D. So vitamin D comes from the sun. And when you're out in the sun in your tank top and your shorts, your skin is bringing in more vitamin D than it is during the winter when you're all covered up and there's hardly nothing that can be seen by the sun. The other thing is that the sun is out longer during the summer than it is during the winter. Then we have to look at underneath of that, what is the differences between men and women as to why women can have depression or the effects of depression more often than men, which is something we'll also get into. Now, when we look at bipolar disorder, we have the depression symptoms on one side, which I already sort of went over, and then we have the manic symptoms that are the sheer and opposite extreme of the depression symptoms. And so for a bipolar disorder individual, you would have to have both of those in order to be diagnosed with bipolar disorder. When we look at a bipolar brain, the very first brains at the top are the control brains, which means that they're the brains that are functioning normally. Okay? And so you can see how much the dark blues compared to light blues, greens and yellows are lighting up. Then that brain has moved into manic mode, and you can see almost everything is lit up to an extreme, and it stays that way for extremely long periods of time. Now, I will have people tell me, oh, I'm bipolar because in the morning I wake up and I'm fine, but by the night I'm not. Or in the morning I'm manic, but at night I'm depressed. Or I can move it from 1 hour to the next. That's not bipolar disorder. Bipolar disorder says that you lie in manic mode for days, weeks, months, and it's even been seen into a year or two. And then you lie in depression for days, weeks, months. Now, you can have a bipolar-like condition, but people will grasp onto that bipolar and say, all right, I'm bipolar. And that's not true. These symptoms are longer lasting, and they tend to mean that you're not bipolar if it's shorter than that. Now, we do have something called rapid cycling, but rapid cycling means that it happens within a 10-day period. It's still not hour by hour. It's over a 10-day period. Okay, and then we can look at the brain that's depressed at the bottom. When your brain in that middle is functioning at the most active capacity that it can, of course it's going to do what it can to save itself, and that means it's going to go into the depths of depression, which you can see in those brains at the bottom. Now, when it comes to bipolar disorder, we find a lot of people, especially famous people, don't want to be treated for bipolar disorder because they find that they are at their utmost capacity for creativity in manic mode. So if they treat it, even if they are treating the depressive portions of it, it'll shoot them into manic mode, and they find that they're not as creative. So they don't want any diagnoses, nor do they want any assistance with it because that creativity. We see that most often with comedians, and as you can tell, I have some comedians here, and one of those 3 comedians actually committed suicide during the depression version of the bipolar disorder. So there's ramifications of this. For the rest of them, I want you to look at them and see, are there times when they're on television doing every talk show there is, they're doing 3 or 4 movies at the same time, they're doing stand-up comedy, they're everywhere doing everything. People will ask them, don't you need to sleep? And they're like, oh, I'll sleep when I'm dead. Or there's a reason for them not sleeping. It's actually manic mode. And then all of a sudden you'll find that they just disappear. You haven't heard from them for a while. That means they're in depressive mode. Now, when it comes to all bipolar disorder, there are periods of norm. So just like the brains that I showed you earlier, there's manic, and then they can go to depressive, and then they can go to a period of norm as well. So they all have periods of norm. Now, at the bottom of this slide, I have a link for you to click, and it will show an individual that wrote up a report or wrote up a video for me, did a video so that they could show me what it feels like to be bipolar. So please view that. Now, understanding our mood disorders. Again, we're looking at the United States, and we're looking at males compared to females. Males are in red, females are in green. Now, people ask me about Spain, what happened there. Spain's numbers have been transposed right now, so those numbers mean that they actually go the opposite direction. All right. So let's look at why is it that women are more susceptible to any of our mood disorders than men are. Does not mean that men can't get mood disorders. They absolutely do. But we tend to find women are diagnosed with it more often. So first and foremost, women ruminate. Rumination is when you worry about something over and over and over again. So let's say a breakup. They not only worry about it constantly, what they could have done, what they should have done, how much they hate that person, how much they wish that person was back, whatever the thought process may be. For the first few days, it's weeks, it's months, we will find that even when they're in another relationship, they'll be worried about what happened in that past relationship, potentially happening in this relationship, so that it's a constant all the time. Women will go to sleep, or try to go to bed, I should say, and they can't go to sleep because they're worrying about what's going to happen tomorrow, worried about what's happened today, worried about something that they said, and so they can't sleep because of that worry. It's called rumination. Many women will even wake up in the middle of the night worrying. Again, rumination. Now, the other thing that we know between men and women is that there's a wider range of emotions for women. So they have deeper depths of depression, but they have higher levels of euphoria, and that's without bipolar disorder. So they can describe what joy feels like compared to just happiness. When we look at men, they have not the depths of depression that females do. They have a deep depression, just not to the same extent. And when it comes to the above aspect, they also don't go as high. They're happy, but not to that extreme joyous that women can have. So because women have a wider range, they can have a deeper depression, and therefore their depression takes more effect. Now, women take on more stressors as well. Some of these stressors are caused by ourselves, but it's also the way we've been raised. It's also the way we look at things. So our stressors are, for instance, multitasking, doing everything for everybody else. So let's take a look at just relationships and the way women look at those. So women look at relationships as what I do for you shows my love. Not just telling you I love you. Everything that I do for you proves that I love you. So a woman will start in a relationship, and as she's sitting there at his house, she'll do his dishes. She'll cook for him. She'll clean for him. She'll pick up after him. She'll do his laundry for him. All of those things will happen, and they cause more stressors. Why? She's doing it out of the goodness of her heart, out of the kindness of her heart. But does she have those things to do at her own house? Does she have lots to do, plus job, plus school, plus whatever else is going on? So we tend to think that what we do for others shows them that we love them. And the unfortunate thing is that men don't even typically recognize this whatsoever. They would rather sit down and play the game with them, sit down and watch something with them, have sex. There's all sorts of things that they would rather do than have you running around like a chicken with your head cut off trying to get everything done. And then women will later on feel that stress and use it against others by saying, look at all the stuff I do for you. I do this, I do that, I do, and they'll list off all the wonderful things that they do and say, all right, now what have you done for me? Men don't look at love as what I do for you. Okay? And then on top of that, women will report their depression more. So when it comes to sadness, women tend to be, because they've been taught to be in tune with their feelings. So they recognize when it's occurring. They recognize it's slowing them down. They're not able to multitask as much. So they will report those depression more often to get some assistance. Now, one of the reasons that they report depression more often is women are allowed to be sad and cry. So one of the things that's sad on our tests for depression is, when's the last time you cried? So of course women can answer that easily. If I were to ask a class and I asked all the women in the classroom, and typically this is quite amusing for classes to recognize and understand, I'll ask students in the classroom, go around the room and ask women, when's the last time you cried? And they can remember. They can remember it was this morning, yesterday, 2 days ago. Typically, it's always within a week, and they remember it significantly. And I'll go around and ask the men in the class, when's the last time you cried? And there's silence, absolute deafening silence, where they can't come up with when they cried. Every once in a while I'll get one, but it's usually pretty severe. It's a funeral, it's the death of a family member, it's something extreme that caused them to cry. So that's the differences in being taught it's acceptable to cry to being taught it's not acceptable to cry. So when we ask men, and we can actually define for men their level of depression, it's actually angry. So when I go around the room and then ask men, when's the last time you got angry? They can tell me, an hour ago, this morning. They can respond the same way that women did. And because of that response, we know that for men, that it's anger that we need to look for. What they do is take their sadness, that ability to cry, and transform it into anger. So that cranky old man that that can be a parent, can be a grandparent, and it's just like nothing ever pleases them. They're not happy about anything. They're actually depressed. And if we could correct that depression for them, then that anger would go away. We, of course, always have to bring in suicide and self-injurious behavior. Now, suicide, there's a worksheet for you that is in their modules. And I want you to answer the questions yourself first. And then, of course, I've given you the answers as well so that you can see what is true and what is false. When we look at suicide, we know that suicide can be caused by depression, but is it always caused by depression? And the answer is no. There's many other reasons, and sometimes we don't even know the reasons. Now, why do we link in non-suicidal self-injurious behavior? Those are our cutters. They cut themselves, they burn themselves. They do things that cause physical harm to themselves. What we know is that when you physically harm yourself, it actually stops the area in the brain of emotional pain. So it can distract them from that pain for short amounts of time. And it'll depend on the person, and it'll depend on how long they've been doing it, for a few moments to a few hours to a few days, and then it'll even progress even further than that. So non-suicidal self-injurious behavior is also done for the same reasons. Emotional pain is so severe that they get this tunnel vision and they can't seem to come out of it. Just like suicide, they get tunnel vision, and this is the only answer. It's not that they want to commit suicide, it's that they want to end the pain. And it's the same thing for non-suicidal self-injurious behaviors. They don't necessarily want to harm themselves, but they do want to stop that emotional pain. So because it's done for the same reasons, it's under the same headings. The other thing that we find, many self-injurious people will say, that doesn't mean I'm suicidal. And you're right, it's not a cause and effect, but we do see much higher rates of suicide from those that cause self-injury. What happened is they get frustrated. That emotional pain is overwhelming, and they're not taught how to deal with it correctly. And so many people, once they find out that they've done this self-injurious behavior, instead of getting them the help to figure out how to deal with emotional pain, they just pretend it never happened. It was embarrassing. So they don't discuss it at all. And so later on, what we find is that they won't injure themselves. They will commit suicide because they haven't been able or been taught how to deal with those frustrations, how to deal with emotional pain. Now, when we look at mood disorders, we have to look at the four main reasons why. So we have low self-esteem, causes depression. Learned helplessness causes depression, and rumination causes depression. And another aspect of it is a depressive explanatory style. Now, a depressive explanatory style is this. So there's three versions. So let's say you break up with somebody. A good way to do it is stable or not stable. It is, I'll never get over this. That is the wrong way to look at it. This is going to consume my life. Nothing that's going to ever happen for me is going to happen right because this area of my life isn't working. And they always internalize it as well. It was all my fault. Even if they say, yeah, it's both of us that caused this breakup, you'll find that they're the ones that always work with, I should have. What if I had done? I'm going to do this differently. All of that internalization brings about depression. The correct way to look at it is I will get over this eventually. This is just one area of my life. I still am awesome at work. I still am going to do the best that I can at school and externalize it. It takes two. It was both of us that did this. And then you're going to find that you're able to cope with the situation. That depressive explanatory style has a vicious cycle to it. So you have that stressful experience. Then you go into that negative explanation, which causes your depressed mood. Depressed moods actually change your brain. So depression changes the way your brain functions. When it changes the way you think, it changes the way you behave. Those things cause more stressful experiences, which cause more negative expressive thought processes, and you keep going around in this vicious cycle over and over again. Now we're going to go into schizophrenia. Schizophrenia is a difficult topic to understand, so I'm going to go through it the best way that I can for you to understand it. All right, when it comes to schizophrenia, there's many different causes and there's many different symptoms that we have, and we will go over each and every one of the main ones that are out there. Are there more? Absolutely. The first thing that you need to know, though, for any test questions is what is psychosis. And it means a mental split from reality and rationality. Now, this psychosis is where other people think the world happens in a certain way and they think it's different. They don't interact with the world the way other people can. And it goes to an extreme. Now, one of the first things that are at issue, of course, are hallucinations. Those are one of the most well-known things out there for schizophrenia. Hallucinations and delusions. So first, what is the difference between the two? A hallucination is any kind of sensory input that tells you it's there, but it is not actually there. So it can be seeing things or people that aren't there. It can be hearing things. It can be feeling things. It can be intestinal that says they have things inside their stomach. They have feelings in there that shouldn't be there. There's all different types of them. Any senses that you have that are feeding information to your brain that aren't actually there. So delusions, on the other hand, is the storyline that goes typically with hallucination. We find that they tend to go hand in hand. So you can ask a person, or maybe even you've seen on Law and Order, those people that have tinfoil on their heads, covering the windows, all sorts of stuff like that, and they'll say that aliens are trying to read their mind. The aliens trying to read their mind is the delusion. It's the storyline. Now, how did they get to that belief system? It's the hallucinations that cause them to believe that. Okay, so here's an example of one of the most popular type hallucinations that are out there. We have, of course, auditory and visual that are most well known. This one is auditory. So in our brain, there's two main areas that light up on either side of our brain that show us that somebody's talking to us. So right now, while you're listening to me, these two areas are lit up. Now for them, the two areas are only partially lit up, and then there's a whole bunch of areas throughout the brain that light up that don't light up in a regular non-schizophrenic brain. So it's not just like somebody could tell you that I'm not talking to you when you can hear me. We'd be telling a schizophrenic that what they're hearing isn't actually there, and more of their brain is telling them that it's there than what your brain is telling you when you hear me. So it's even more difficult to try and get them to understand it's not real, because for them it's more real. Now, why is it in areas other than what is typically lit up for our brain? And that's because they have more or less gray matter. We have gray matter, which is like walls between rooms, so that you can it keep certain things in certain areas of your brain. Then you got your little wall of gray matter, and then there's another little area of your brain. And their gray matter disappears. They have less gray matter, and so more areas of their brain not only light up, but it can go through areas and light up in areas where it shouldn't be lighting up, because we're not having that gray matter where it's supposed to be and where it needs to be. Now, different types of hallucinations that are out there. These are the most often heard of ones. There are, of course, more than that. Auditory is the most popular. Auditory means hearing things. Visual, seeing things. Tactile, feeling things. And then, of course, smell and taste. Now, smell and taste a lot of times can be separated, but because they're so linked normally, they've linked them together as one unit. So I also get asked, if it's somebody who's has an auditory hallucination one time, does that mean all of their hallucinations will be auditory? And that's not necessarily true. It can happen. But what we see most often is that they have auditory and a visual hallucination that goes with it. And then the next time they have hallucination, it could be tactile and smell. And then the next time it could be tactile and auditory. And then visual and smell and taste. And then just visual. So they change all the time. What we also do see is that ones that have auditory tend to have most often auditory, or ones that have visual most often have visual, but they can bring in the other ones as well. Now, the types of schizophrenia that are out there, the way your books has looked at it is paranoid, catatonic, disorganized, and undifferentiated. We look at it more like type 1, type 2, okay? And then mixed. So type 1 is similar to the way your book says paranoid. And type 1 actually has to do with more positive symptoms. That does not mean good. That means symptoms that are added to normal behavior that other people don't have. So like delusions and hallucinations. And so of course one of the most often recognized is a paranoid schizophrenic, because paranoia deals with a lot of those hallucinations and delusions that somebody's after them, somebody's going to harm someone that they know, if not themselves. So we tend to call them type 1s. Type 2s tend to be most similar to your catatonics in your book. So type 2s have negative symptoms. Negative symptoms are like a subtraction symbol, and that is that normal people have these behaviors, but these individuals do not. So it can be the inability to motivate. Now, I'm talking about motivation not to go to work. That's not going to happen. But the motivation to get up to go to the bathroom, the motivation to decide to get up, the motivation to decide which chair to sit into. So it'll stop them in their tracks, so they're unable to make that decision because they're unable to get that motivation. It's subtracted from them. Sometimes they are unable to talk. Sometimes they're unable to interact. There's some things that they are unable to do. Now, it can go to the extreme, which is catatonia. And catatonia means that they are unable to move at all. So they not only don't get up, they don't move. They don't, like you're in a chair, you can move your body because you're getting uncomfortable. They will not move at all. So they will become rigid and catatonic. Disorganized, I quite honestly haven't really met too many schizophrenics that are organized. So disorganized tends to go with both groups in your book's definition of it, and tends to go with both groups when we call them type 1 and type 2s as well. Undifferentiated tends to be what we now call mixed, and or we used to call mixed, I should say. That means that you can have type 1 and type 2, or paranoid type by your book, and catatonic type. You can have a little bit of both of those symptoms. Now, it can go 60-40, it can go 70-30, but you tend to have mixed ones to go with it. What we tend to look at, though, for diagnoses right off the bat is which are the symptoms that cause the most problems right now most often. When we look at schizophrenia and its onset, we didn't believe that there was anything that actually caused schizophrenia, or couldn't find what caused it for many, many years. And just like with Down syndrome, we know that mother's age has to do with those disorders. So when she gets pregnant, what was her age span? Now we have found that the age span of the father is what can be at issue for schizophrenia. So we do find that men having their firstborn children at the ages of 45 to 49 are 2 times more likely to have an offspring with schizophrenia. The age of 50 or more is 3 times more likely, and we've now known that the age of 60 to 65 or more makes that number jump much, much higher. So the mother's age has nothing to do with it, but the father's age has a significant contribution to it. Now, it's the same way where mothers can have children when they're older and not have a Down syndrome child. They just are told they have a higher likelihood of it, and it's the same way with men. Looking at those positive and negative symptoms. Now, here's an example of our type 1's positive symptoms. Means that there are these symptoms that other people don't generally have, that don't have schizophrenia. Hallucinations and delusions are things that we have already gone over and are main things that are looked for. Disorganization of thoughts and speech. And when you go into abnormal psych, we'll go into the 4 different types of disorganized thought and speech. And then there's some bizarre behaviors that can go along with it. When we look at the negative symptoms or symptoms, things that are subtracted from normal behavior, no emotion whatsoever, social interaction, no feelings of enjoyment, no motivation, speaking less, and then of course catatonia can take place. So positive symptoms adding behaviors and symptoms, negative symptoms subtracting behaviors and symptoms. Now when we look at the onset of schizophrenia, we have to look at what our prevalence is. Now, we tend to look at schizophrenia as a genetic-based thing. And, of course, there's different reasons that it'll come into it. It tends to stay with the same prevalence no matter what, no matter where in the world. It's about 1 in 100 people. It is now slightly more women than men. It used to be more men than women. And then your book covers what's called acute or reactive or chronic schizophrenia. Now, we never, when I worked, didn't call it acute or reactive. Acute or reactive is short, it's a psychotic break. And I'm quite sure you've heard of it in the criminal justice system where they've just had a psychotic break, lost their shit, now they've come back and everything's fine again. It means that they have a short onset of symptoms. It can last for an hour to a couple of days, but then it's gone. Gone. And they may not ever have it again. Now, typically we don't diagnose that as schizophrenia. Schizophrenia is chronic or process. True schizophrenia means that they can have positive or negative symptoms, and they've had these for 6 months or more. And once you have schizophrenia, the true diagnosis of schizophrenia, it's not something that can be fixed, ever. There's no fix for it. It's a done deal. Now, there's other terms that have schizo in the front of it that people will automatically go, I was diagnosed with schizophrenia. Well, if you're in my class, you're talking to me, and we're interacting, and you're understanding what I'm talking about, you don't have schizophrenia. You may have something that is similar. There's schizoids, there's schizotypals, there's bipolar disorders there's personality disorders that have some schizophrenic symptoms, but it doesn't mean that schizophrenia. So understanding schizophrenia, we have to look at what we know takes place. So the first thing is D4 receptor sites. We know it's the D4 receptor sites in your brain. You got lots of them. But with those D4 receptor sites, they release dopamine. Now what we found with them is it's not just that they're shooting out lots of dopamine over and over and over again. It's that these D4 receptor sites are wide open so that they're shooting out massive quantities of dopamine. And it's constant. It's never ending. It's never stopping. Now, they've tried to give them medications because like Parkinson's disease is where you're not getting enough dopamine. So they give them medications to try and slow down that dopamine so it's like Parkinson's. But the problem is that there doesn't seem to be with these D4 receptor sites a happy medium. It's either all or none. You're getting so much that there's no way to stop it, and it's just inundating that brain with dopamine, or it shuts it off and they're not getting any. So then it just sends them into a Parkinson's-like syndrome. And so there's problems with trying to correct those D4 receptor sites and why there's not a cure. The other thing that we know and we're not quite sure of, the frontal lobe, that prefrontal cortex, which holds your personality, all sorts of good stuff in that manner, tends to be something that shrinks in size. It doesn't work or function as well. So when we're looking at that shrinking in size and not working as well, it means that when you're getting those hallucinations, delusions, or that lack of motivation, the areas that recognize that that's not happening or shouldn't be happening aren't there to function to actually contradict or counteract those situations. Then we know that the thalamus fires a great deal as well, which really sets off those hallucinations. And then we have that shrinking of the brain that goes along with that frontal lobe not working as well, and the whole brain tends to shrink. We are not sure if that happens at the onset or if that happens after the onset. The problem is when we look at those brains, we don't have a whole lot of information prior to onset because we're not looking at people before they could potentially get schizophrenia or looking at their brains beforehand. Understanding schizophrenia. Now, a couple of these things are not cause and effect. So the father's paternal age is a cause and effect. We know that oxygen deprivation can be a cause and effect. It's what we call anoxia. And anoxia is where you've deprived the brain of oxygen either at birth or soon after birth, and depending on how long will cause many different disorders. One of those different disorders that it can cause is schizophrenia. The ones that we look at more as a co-relationship, otherwise known as correlational, is low birth weight. Now, here's why it's correlational. We've taken schizophrenic patients and then done research on their history and found that they had low birth weight. But that's just like looking at the vaccinations thing and saying found that they had vaccines at a certain time. So do other people. So there are a lot of people that are low birth weight that does not necessarily cause schizophrenia, but we are seeing a co-relationship. Maternal diabetes, meaning that they don't have diabetes normally, but they have it while they're pregnant. Famine is another one that has moved into the cause and effect. Famine is when you are not getting the correct foods to develop that child correctly. So that's why we've come up with WIC and our EBT, where you get food, because the brain can't develop unless it gets the correct amount of protein, unless it gets all the nutrients it needs. Now, many people will say, well, wait a minute, I can eat ramen 24 days or 24/7 every day of the month, etc., and I'm fine. That's not, no, you're not. That's not providing you nutrients. Ramen doesn't have nutrients. And people that are poor will buy those things so that they can eat because it'll make them feel full, but it's not giving them the nutrients that they need. And then they'll feed their children the same thing, and it's not getting them the nutrients that they need either. So famine can happen when your tummy is full. It's just not getting you the nutrients that are needed for correct brain development. And then one that is starting to become more popular is a maternal virus during the second trimester of a pregnancy. So they will get a virus, a cold, the flu, something like that during the second trimester. And we tended to see that when we looked at the history of those with schizophrenia, that they found these antibodies were in them that came from a virus during the second trimester. Again, not enough research, not enough data to say that this is a cause and effect relationship. Now we're going into other disorders. Looking at other disorders, we're going to look at phobias, we're going to look at anxiety, post-traumatic stress, that kind of thing. One of the first things that we're going to go over in the other disorders that we have is anxiety, and a few different types of anxiety. Of course, there's more than what we're going into, but this is the list of the ones that we're going into, and then some of the causes that we'll get into more in depth as well. So generalized anxiety disorder is the one that we find most people with anxiety have. And it is just like what it sounds. It's generalized, which means they're not sure what it is. They can't put their finger on specifically what the problem is. They tend to be worry warts. They worry about everything. It's called a free-floating anxiety, where they tend to be that sympathetic nervous system kicking into gear, even though there really isn't a need for it. It's not as if they've seen a snake. They don't know what it is that causes them to feel this way. Now, it interferes with memory, it interferes with thinking and concentration, focus. We find that it also can interfere with relationships, of course, because making a decision becomes extremely difficult because none of the decisions are acceptable because all of them are worried about. So I have three questions for you to look at that may lead to generalized anxiety disorders. So let's take a look at those three. The first one I have is, do you develop physical symptoms in response to stress? Physical symptoms, stomach aches, headaches, nausea, diarrhea, constipation, body aches, anything like that. Is it rarely or not at all? Sometimes, often, or almost every day. So either in your mind or write it down. Which one of those things is it for developing physical symptoms in a response to stress? The next one is, do you ruminate or fixate on the same worry over and over again? Now remember, ruminate is just worrying and worrying and worrying and not being able to stop. And many times that worry is about things that you have no control over, yet you can't seem to get rid of it. You lie awake at night, or you wake up with worry, or you just have this continuous thought process going on even if it's during the day. Again, rarely or not at all, sometimes, often, or almost every day. The third question is, do you feel it's dangerous, almost like it's tempting fate, to feel confident that things are going well? So you say something about things are going well, and then you're really worried. You got to knock on wood. You've got to keep your rabbit's foot with you. It feel as if anytime you say something's going well, it will go wrong. So you really don't like to say when things are going well. Is that rarely or not at all, sometimes, often, or almost every day? Now, out of those three questions, if you have one of them that you really find is an often or almost everyday thing, then it is a leader towards generalized anxiety disorder. It is a concern that will get that pumping and going on a regular basis. If you have two of them, then it's definitely a concern and you need to start to take care of that. All three of them, we are definitely at the generalized anxiety disorder door, if not already well into it. So here's our anxiety disorders we're going over. The main thing I want you to look at on this page is the men compared to women. So we have GAD, of course, more women than men. Panic disorder, women are 2 times as likely as men. Phobias, women 2 times as likely as men. So you're seeing sort of a theme here with women. Post-traumatic stress disorder, the most well-known, is for veterans. But we find that there's another group of people that actually have it more, and that is women that have been assaulted and raped. So there are so many more women that are assaulted and raped that they outnumber the veterans, whether men or women, when it comes to post-traumatic stress disorder. And then we have OCD. Now, obsessive compulsive disorder is dead even. It's 50-50 for both men and women. Now, I hear most often about it with women, but it is actually diagnosed dead even. So after generalized anxiety disorder, we're going into panic attacks and panic disorder. Now, a panic attack is otherwise known as an anxiety attack. And there's this intense feeling that you need to escape, that there's something wrong, that you're going to die right then. So I will have and have had students that will say, I'm away to school, I got out of the car and all of a sudden had this panic attack where I just knew I had to leave. I couldn't go any further. I couldn't stay there. I had all these symptoms. I was sweating. My chest hurt. My arm went numb. In fact, all of the symptoms for a panic attack tend to be the same exact symptoms that there are for a heart attack. That's why if you go into the hospital and you're having a heart attack, they will check with an EEG just to make sure, because so many panic attacks are, every symptom is exactly the same. Now, I also have students that will talk to me and say, well, I wasn't quite there. I just knew I had to leave. I wasn't having chest pain. I didn't have the arm thing. You're still having an anxiety attack that it can get worse and will get worse if you don't get it under control. So you need to get these under control. The other thing that I have with panic attacks is that when you feed into them, when you allow them to happen and you go home, people will tend to think that the place that is causing the problem was wherever they're at. And that's not true. It is your brain trying to shut you down. And your brain is actually saying to you, hey, you've had this issue for a while. You've got something going on, whether it's, something at work or something at school or something at home. And whatever it is, you've got this going on. And it takes a while to get through your brain before your brain finally says, all right, I'm shutting you down, or making you feel like you're having a heart attack so that you'll finally take care of this. So it doesn't necessarily happen right then. And in fact, what we find most often is it rarely happens right then. But people will align wherever they're at as the issue. And what you really have to think is, what is it that is really bothering me? What is it that is really causing me to feel anxious or concerned? Or where's my confrontation that needs to happen? And then deal with that. You'll find the panic attack will go away. Now, if you don't take care of it, you're going to have not only one panic attack, but then 2 and 3 and so on, and it becomes panic disorder. So you do have to take care of it. You have to figure out what the issue is, take care of that issue in order for you to start to deal with these panic attacks. The way your brain works is, once it's given you a panic attack, it is like walking through a field. There's no path there. Then you walk through the field and you can see a slight path there. So that panic will happen again because there's already a path towards panic attack. Then, because you've had a second one, it's matted down more, so the path is more permanent and easier to get to. So the next panic attack will happen, and it'll come quicker and easier because you've already made a path. In order to undo this, you have to undo that path that says this is the easiest way and this is the only way I'm going to deal with anything that I have at issue. So make sure you take care of it so it doesn't turn into a panic disorder. Many times when it's a panic disorder, you need assistance to get out of that pathway so it doesn't continue to happen again and again. Now, mind you, panic attacks can also lead to hermits, where they won't come out of their house. It's a type of anxiety disorder because you're fearing the next panic attack, so you won't go out because you're afraid it's going to happen. And we'll get into that as well. Specific phobias, of course, it's an uncontrollable, irrational, intense desire to avoid some kind of object or situation. Now, many people confuse fear with an actual phobia. Fear, yeah, you may scream, you don't really dig being around it, but many people that are just looking at these pictures are done. They're not able to work with it anymore. Here's the thing, when it comes to this, you have to control the phobia. So you have to, the more you're engaged with it, the more you're around it, the better you feel about it. So you can't let it take control of you. You need to take control of it. Of all the disorders that we can correct easily, it is actually phobias. Even of the most intense phobias that are out there, it is one of the easiest things to correct, and many people can correct them on their own when they work at it. Now here's some of our fears and phobias that are out there that are most of the common ones. Notice how much larger the fear section is to the actual phobia. So many people that say that they've got a phobia actually have a fear. And then here's a couple other phobias that are out there. That agoraphobia is the one that I was talking about, where you become a hermit because you're afraid of going out because you're going to have a panic attack. So you don't go out, you stay in your house. So you avoid all types of situations. And then we have social anxiety disorder, which is this feeling that you're being watched by others and you're terrified of being embarrassed by those public experiences, and they can also lead to that agoraphobia. Now, social anxiety disorder can be, speaking in front of a class, or it can be just society as a whole where you're afraid that everybody's looking at you. You're the specific center of attention. And then what we find with that social anxiety disorder is it tends to be individuals with lower self-esteem, feel that they are not pretty or good looking. They have negative concepts about themselves, which cause them to believe that others will have those same negative concepts about them, and that causes that fear of being watched or seen by others. We have four main categories of phobias. One is situations like bridges, tunnels, elevators, enclosed places. Another one is natural environments. It can be heights, it can be the weather, it could be water. Thunderstorms are a big one. Injury or blood, they always crack me up because they tend to pass out the minute they see blood. Um, there doesn't tend to be a whole lot of in between on that one. Animals and insects, of course. So what are some of the reasons why we have phobias? Classical conditioning is one of them, where there's a traumatic event that has taken place, so now they're fearful of all things associated with that traumatic event. Observational learning, I have written on there water, and here's why. Around here we have the lakes, so of course every parent wants to be a good parent, take their kids to the lake, but then the ones that already have the fear of water will be the ones that aren't going into the water with the child, or when they do, you could just feel the fear emanating from them. Or they stand on the beach and they yell to the kid, you can't go past your knees, don't go over here, don't go over there, you're too far out. And really they're not far at all. And they seem to be continuously, concerned all the time. Kids register that, they understand that. So they soon learn when I'm out of the water, mom and dad are calm. When I'm in the water, they're not calm. That must mean there's something in that water that I should fear. And so they'll develop that fear of water because they see that fear of water from others. And then there's also genetics involved in it. And so we do see a pregenetic disposition to it, where we've seen with identical twins that were raised apart. If one has a certain phobia, so does the other one. So we know there's some genetics in there. But we also know that through human evolution, we have this idea that anything that's filthy, gross, anything like that's going to cause us to get an infection, going to cause us to get sick somehow. So that also is linked to some of these explanations for a phobia. Now here's a question for you. What is a phobophobia? Is it a fear of developing a phobia, a fear of phrenology, or a fear of becoming a hobo? It is actually a fear of developing a phobia. What we found is that you can have a phobia for anything and everything out there. There's anything. So I'll show you examples of phobias, but this one is just showing that people can be so fearful of developing a phobia that they actually develop a phobia for a concern about getting a phobia. So here's some of those phobias that are out there. There's one where I've actually worked with somebody that had the fear of the right side of their body. It can also happen with the fear of the left side of their body, but they pretty much don't use the right side of their body at all. They pretty much ignore that right side. it's almost as if part of their body is trying to attack them, and it's very life inhibiting for them, of course. There's all sorts of fears, like a big one that's known as the number 13. So I always get asked at around Halloween, or if there's a lot of Friday the 13th, that kind of thing, about the fears and about the fear of the number 13. And so people with the fear of the number 13 not only will not use the number 13, not only will not go on the floor that's the 13th floor, they won't buy a house that has a 13 in it. They won't, many times, even drive by places that have 13s involved in them. They'll go way around. So when we're talking fears compared to phobias, there's a completely different understanding of the two of them. The next one we have is obsessive compulsive disorder, and it has to have two parts to it. First, it has to have the obsessions, which are the intense ideas that you have that cause you to worry. And then you have to have the compulsions that go with it, which is an action to make the obsession idea feel better. So you must have both. And it has to cause you distress, and it has to be some kind of dysfunction where it is not like what other people do, and it does interfere with your normal living skills. So I've had students that come in and say, I'm obsessed with my house being clean. Many times it's because you're single or live with one other person, don't have children. And so maybe you like everything in its place. Somebody else will walk in and turn something just to annoy you, just to aggravate you. Do you find that if you go to work and you know that that thing has been turned, that you must leave work to go and fix it? That you must do the action, or you cannot actually complete your day? If that's true, then we're looking at obsessive compulsive disorder. I have many students that tell me, I like to color code everything. I like my shirts and clothes perfectly aligned. I can't stand it when they're out of order. Again, this is an anxiety thing, and the only way that you can undo it is to force yourself to undo it. Now, watch some of the videos that we have on obsessive compulsive disorder to help understand the differences. Now, common ones that we have out there. The main thing that I want you to do, you can read those, is the rechecking. So I'm going to show you an area of the brain in a little bit that lights up. So maybe your house got broken into, a traumatic event started this. So now you go around, first you sit on the couch, and as you're sitting there, you think, did I lock the doors? Did I check all the doors and lock those doors? Now, even though you know that you did, the area that lights up in your brain will start out at a small little pin size area, and then it just keeps getting bigger and bigger because you can't get rid of that obsessive thought process until it goes to its full size. And that's the picture that I'll show you. And then as soon as it does, you'll have to go around and recheck those doors. Now, typically this is not a one-time deal. So rechecking tends to be, it can be aligned with a number. So you may have seen things on television with OCD or whatever where somebody has to tap the wall 6 times, or they have to turn a knob 12 times, or something along that line. This is the same thing. We've tried to look at where the numbers come from. How did that number just arrive? And many people will say that they have no idea. But then when we really started to delve into it, we started to find that this can be a favorite number. This can be a number that you think maybe is a lucky number. It can be the number that you always play when you're playing Powerball or anything like that. So what is your favorite number? And that can be the number of times you have to check it. Now, that's not where you're going to go around to those doors. Like maybe your number is 6. You're not going around to those doors 6 times all at the same time. It means that you have to let that area in your brain while you're sitting on the couch light up 1 time. Go around, check those doors, sit back down, let that brain get big again and lighting up and saying, we got to do this, go around again. And you have to do that full thing 6 times. Now, I know of people whose favorite number is like 41 or something like that. Does this interfere with your daily living skills? Absolutely. Now, who suffers from OCD? Cameron Diaz, Leonardo DiCaprio, Howie Mandel, or David Beckham. Make your choice. Now, most of you probably chose Howie Mandel out of this. And you're right, Howie Mandel is. But it's actually a trick question. All of them do. So, first of all, Howie Mandel is a germaphobe. A germaphobe, I always say that you have to be rich to actually really do OCD because with Howie Mandel, um, so he's bald, he shaves his head because he feels that there's germs in his hair, yet he has a goatee. Your OCD belongs to you. So you get to decide what is dirty, what isn't dirty, what will be acceptable, what isn't acceptable. It's not like logic plays into this. So even though he shaves his head, he has to wash his hair every day. And so as soon as he opens up a bottle of shampoo, it is now contaminated after first use. So he can never use it again. So yeah, he can use those little shampoos like you get at a hotel, but still after one use, no can use again. Same thing with toothpaste. Same thing with toothbrushes. Same thing with razors. Everything that you use, once it's open, it's contaminated. You certainly can't eat at a place where you're at a buffet. And many times what he does is he doesn't go to even buffets, but when he goes to a restaurant, he brings his own dishes, he brings his own silverware, he brings everything with him, and most of the time even brings his own food. And the reason is contamination and this OCD. All right, next, Cameron Diaz. Now, Cameron Diaz has this thing with doorknobs, and it's an actual doorknob, not a push thing, a doorknob. And so, in the past, doorknobs were the only way that you could open anything. And either what she has to do is not touch a doorknob at all, because of the contamination factor, or when she touches the doorknob, she has to rub it until all the paint comes off of it. And that rubbing can last not just hours, but can last days. So what she finds is it's best to just not touch them at all. So when I first heard this, I thought, oh, that's not true. I've seen her open doors. So I took every movie she's ever been in, everything I could ever find on her. And what you'll find is see her body going to open a door and a hand opening the door. But you will never see the hand connected to the body opening the door. She actually has a hand double to open doors for her. Leonardo DiCaprio has a couple of things. I always say that one day I'm going to go to jail for him for stalking because I have to do research to find out a question about this. So one of the first things that he has is that he can't step on a crack. You know the old saying, step on a crack, break your mother's back. We have found that a lot of fears and phobias can come from these old things, but he can't step on a crack. But then the second portion is he must step on gum stains. Now, you know when you chew gum and you drop it on the ground, maybe on cement or anything like that, when the gum goes away, there's a stain from that gum left there. And he must step on it. And he must step on it in the center of his shoe towards the top, just below his toes, you know, in that fat part of your foot. He has to step on it right in the center of that. So I don't know if you've come up with what I'm going to jail for stalking, but what if a gum stain is on right on a crack? And so how does he put his foot on there when he can't step on the crack? And what does he do? Shimmy both of his little shoes up there, or what happens? I will research that one day. I will let you know what I find out. Then we have David Beckham. David Beckham is symmetry. So supposedly has quite a collection of shoes, almost like a classroom full of shoes, tennis shoes kind of thing. And even though I've seen him play and he just bends down, ties his shoes and everything's fine, he goes on about his business. When he's at home and when they're in a closet, they need to be perfectly aligned from how far from the back of the closet to the front of the shelf. They need to be perfectly aligned to the millimeter between one pair of shoes to the next. There's a certain amount of space between the left and right shoe. There's a different amount of space, and that must be perfectly aligned as well. Supposedly, he also the laces have to be exact to the millimeter when they come out. It's not like you just want them even. They have to be exact to the millimeter. The bows, when you do your little bunny ears, have to be exact. Even the curve of that lace inside the eyelet has to be curved exactly the same. And supposedly there is a device that has been created to make sure that that occurs. Is that true or not? I wonder about it. I do not know the extent. I did read it in Psychology Today, and I couldn't find a whole lot more information on it, but boy, is that amusing to know. Post-traumatic stress disorder is next. With post-traumatic stress disorder, most well known with veterans, we do know that it is most popular with rape victims, assault victims, and whatnot. So civilians have it more than vets have it, even though vets are the most well known for it. Now, what is post-traumatic stress disorder? It is where they have nightmares, they have reoccurring daydreams about it, intrusive memories about whatever the event was. They're hypervigilant, which means that they're always on point, waiting for the next disaster to happen. So, of course, they don't sleep well and have lots of sleep problems. They tend to withdraw from society, from family. They don't ever want to talk about it because they're concerned about the way others feel about them and about whether that hypervigilance will make them overly reactive to other people. Now, how does this come about? We do know that the more trauma you have as a child, the higher the likelihood of developing post-traumatic stress disorder after a trauma in adulthood. So the more trauma you see, the more trauma you've had, the higher the likelihood. So when we look at it's not just childhood, the more trauma you've had as an adult. The unfortunate thing is with rape victims, once they've been raped, they have an actual higher likelihood of being raped again. There are many reasons as to why, and most of it actually deals with the rapists themselves being able to recognize who has concerns and who doesn't, and who has fears and who doesn't. So, we're not going to go into all of that, but when it comes to post-traumatic stress with veterans, we know the more tours of duty that they do, the higher the likelihood of post-traumatic stress. 2 tours of duty, double the likelihood. 3 tours of duty, triple the likelihood. So we have what happens is a limbic system in your brain that once it gets sensitized, then it can become overly sensitive to new information and new traumas coming in. Now, when we try to understand anxiety disorders, there's several different explanations, and some of them we've really already gone into. And these are the 6 main reasons why anxiety disorders even take place. And that's why in the United States, anxiety disorders is our #1 disorder. #1 disorder. So observational learning was one of the ones that we talked about with the water. It can also be observational learning where you see that your mom's terrified of spiders and she screams all the time. So you've learned that that's a horrible thing. So you become afraid of it as well the more you observe it. Cognition has to do with that hypervigilance and persistently looking out for danger, knowing it's coming, anticipating it's coming, so that you'll recognize danger and trauma well before everybody else does. And if it even actually is danger or trauma, it will be to that person. Rumination is also a cognitive issue with anxiety, that worrying constantly over and over again. Biology, of course, there's that genetic predisposition. Temperament also has a lot to do with it. Those that were colicky children that, a high level of need becomes a high level of need as an adult that causes more anxiety, so they can be more prone to it. We also know genetically with the neurotransmitters, there's issues with serotonin that causes problems with anxiety, dopamine that causes problems with anxiety, and glutamate. Glutamate is an excitatory neurotransmitter, and it makes you alarmed even when there isn't something to be alarmed about. Now, here's that area of the brain that I talked about with that rechecking for OCD. So you can see the yellow with the red around it. And it'll start out like a little pinprick, and then it'll get bigger and bigger. And when it gets to this point, you've got to get up and recheck those doors. Dissociative disorders is next, and there's two main ones that we're going to go into. We're going to discuss dissociative fugue and DID, dissociative identity disorder, which used to be called multiple personality disorder. So it is a disassociation from your memories, from your understanding of the world, from your identity or your personality, either one of them. So a dissociative fugue. Typically what we find is that it is some version of amnesia that takes place. So maybe you're in an accident. Afterwards, you can't remember who you are or anything about you. That's typical amnesia. But what is added to this to make it a dissociative fugue is that all you know about yourself is that you need to run away. You need to get away. That it is an unsafe situation. We have no idea why. We find that it is not unsafe situations for them, but they will run away. Now, just like any amnesia, it will come back at any point in time. So it could come back within a couple of days, couple of weeks, months, but it could be years before that memory comes back, and then they recognize. It can be as bad as recognizing they have a family someplace else and they currently have a new family. And, who do they love now? Both of them. And it can be quite a big deal. Now, most often we find that it lasts for shorter periods of time, but can last very long. Dissociative identity disorder used to be multiple personality disorder. Now, what happened here was multiple personality disorder got a bad name. There was a movie that came out about an individual, and they found that the whole thing was BS. So they found that this was untrue for that individual, and so there was this big uproar over it where everybody went to try and disprove multiple personality disorder. So while they were trying to disprove it, they actually proved that it existed. But multiple personality disorder had gotten such a bad name that they renamed it to dissociative identity disorder. So let's take a look at how they reproved that it actually existed. Now, it is more than just what you've heard of where it was they could speak a different language. Yes, they can. Some of them can. And when they speak a different language as a different personality, you'll find that they have never had a class in that, have never seen it on television that we can prove or anything like that. And so because there was that question of, well, can it happen or can it happen? Did they actually know that language before or not? They didn't really want to use that one, except when it got real specific to dialects in certain areas. The whole thing with dissociative identity disorder is that a person has more than one identity. Now, if you have, now I can't recall the name of it right now, but there's a new movie out that discusses DID, multiple personality disorder, and it's actually very good. It was one of these ones where I don't go to see movies that talk about disorders because they do it for drama. They change all sorts of aspects about it. And with this one, for the life of me, I can't remember the name of it. For this one anyway, he becomes a monster. One of his personalities is a monster at the end. That is the drama portion of it. All other personalities prior to that are all true. Did it well. There was a child that was a personality. There was a woman that was a personality, and it was actually a man. There was an older person. There was all sorts of different things. And the way it was actually produced, the way it was actually done was extremely good, and they did a very good job at it. I had to stop and look up the movie. First, the movie that came out that was proven wrong was Sybil. The second movie that right now is out that is actually very good, well, it actually came out a couple of years ago, is Split. So take a look at that if you get a chance. Monster, not true. Rest of it, very good. So, next one we have eating disorders. Eating disorders. We have anorexia, bulimia nervosa, and the binge eating disorder, which is the newest one added to the DSM-5. Anorexia you've probably heard of most often, where they won't take in fat or sugar or any kind of calories because they want their weight to be extremely low and to make sure that they're underweight. Bulimia nervosa is most well known as the binge and purge. They'll take in large quantities of food, but then they got to get rid of them. Most often it's well known for vomiting in order to get rid rid of it, but they'll take laxatives, diuretics, they'll do anything to get rid of it. Extreme exercise is another one. Binge eating disorder, newest one added, and it doesn't have what we call the compensatory behaviors of bulimia nervosa, but they do binge eat. It's somebody who takes in large quantities of food. They feel guilty afterwards, but they don't do the compensation like bulimia nervosa. Now, mainly what we found is that they know that for bulimia nervosa, the purge doesn't actually get rid of the calories. As soon as that stuff hits your stomach, 50% of it's going to remain there. And then the rest of it they're looking for is actually in weight content. So they brought in 2 pounds of food, they're going to take out 2 pounds. So it doesn't actually work out the way bulimia nervosas typically think it will, and makes them on a roller coaster of gaining weight, losing weight, gaining weight, losing weight, and they tend to gain back more than what they lose. The binge eating people eat large quantities of food and can't stop eating large quantities of food. So typically, of course, obesity is a huge issue. Now, when we look at eating disorders, what are the main reasons for it? Anorexia has a big issue with parents and tends to be mothers most often, unfortunately. If the mother is overly concerned about her weight, the child will then be overly concerned about their weight. We also find that if parents call them names or tell them that they need to be on a diet on a regular basis or anything associated with being overweight, that it'll push towards the anorexic side and the bulimic side as well. Then we also have in society these ideals that we've put out there on what we should look like. Now, for anorexia and bulimia, that is mainly a women thing. We are having more and more men get involved in it and doing it, but it's still mainly a women thing. Like anorexia used to be 99.98% women, and now it's 96% women. So we're still way up there in numbers. So we have this unrealistic ideals of what a woman should look like and compared to what they actually are. Now, why is it we have this raise in men from, 0.02% or whatever it was to 4%? And that is because the media has since changed. It's not just about women and these ideals. Now it's about men and these six-pack abs and billboards about it, media about it, movies about it, all that kind of stuff. Then they make it very glamorous as well. They show that you're perfect when you're anorexic, when you're as scrawny as can be for a female and as six-pack as you can be for a male. So lots of these photos are about it. Just go through the checkout aisle and look at all these pictures that they have where they look at somebody that's got normal body and in fact below normal body weight, and they will say, oh my God, they must be pregnant, or there's something about, this little tummy that they have. Instead of worrying and being concerned about other things, they're worried about their body shape. Now, of course, Barbie always comes into play, and so this is just a picture of what a real woman looks like, and then if we made her into a Barbie, what she'd look like. Her arms and legs would be highly extended. We'd have to remove 2 to 3 ribs on both sides. The neck would be elongated. The head would be elongated. There would be a whole lot done to alter what a real woman would look like to make her look more Barbie-like. She'd also have to have a pinky toe removed. Personality disorders comes next. We have 3 what we call clusters or categories of personalities: anxious, eccentric and odd, and then dramatics. So when we look at personality disorders, know that this is embedded in their personality. This is who they are. So can we fix it? The answer is no. Even when we look at and try to work with them through psychological therapies and whatnot, we can get a percentage of improvement, but those percentages are extremely low, like a 3% change, a 5% change, that kind of thing. You're not going to recognize that in a relationship as much, where we can recognize it on paperwork. So essentially, this is a done deal when it's a personality disorder. So we're going to go into the 10 groupings underneath of these three sets of clusters. Okay, here's our three clusters, the odd, the dramatic, and the anxious. First, we're going to go over odd. Now, these are the ones that are most like a schizophrenic, and that diagnosis can make them lead to believe that they're schizophrenic, but this is a personality disorder. So the first one is paranoid personality disorder. Now, examples of that, with a schizophrenic, their paranoia can be somebody's going to harm them, that somebody's going to harm people around them. And they're paranoid of that, or they think that aliens are coming at them, anything along that line. This is distrust and suspicion of others, but it's more on a level that is understandable, that people will think, well, yeah, maybe that's true. It's more along the line that they think that their neighbor is constantly encroaching upon their property. They're putting a fence on their property. Even though it's been surveyed several times, they'll say the surveyors were paid off, and that's not actually correct. They believe more believable things, but they're paranoid of others, suspicious of others. Schizoids have a detachment from social relationships. They don't want to be with others. If you've ever watched those movies or television shows about people way up in Alaska, now it is actually not normal for people to want to live way far away from everybody else. We are pack animals. We like to be in packs. We need relationships. So when it's somebody who doesn't want relationships with others, it's because, and they have a detachment, they don't have feelings of others at all, then we have more problems with the schizoid disorder. They tend to be very sober, again, that term that's come up before, where they don't tend to have a whole lot of personality for others, or a whole lot of emotion, not a whole lot of joy or sadness. They just seem to be sort of flat in between there. Of course, all of our personality disorders are going to have a great deal of problems with criticism from others, and this is one of them as well. Then we have our schizotypals. Now, I had to laugh when I was watching one of those Alaskan shows because there was a schizoid family, and they said that they were going to go up and visit their uncle, who lived way further away than even what they did up in Alaska, and they were by themselves. They were supposedly married. The person that they were married to and they had a child with lived in a completely different state, hadn't seen them for 13 years or so. And this person, the schizoid, said, oh, my uncle's really strange, so I want to prepare you that they're really, really strange. So schizotypals are the closest in behaviors to a schizophrenic. But when a schizoid tells you that they're going to see a strange person, more than likely you're going to what I call schizotypal land. So they're very superstitious, brings in the paranoia, brings in the schizoid, and then they have some really odd behaviors and mannerisms that go along with it. Now we're going to go all the way over to the right with anxious and fearful. We have avoidant personality disorder. That's where they avoid others. They avoid social interaction. They feel mainly that the avoidance is because that they're inadequate themselves. They don't want disapproval. They're very fearful. We find most often this comes from parents that are avoidant personality, and then as they're raising their child, they can be abused, they can be neglected, and they avoid others because they're terrified that they're not going to be in a relationship like what they want. They can see things that they want, they just can't get there. Now, will avoidants be in a relationship? They will be in relationships, but it's not a give and take relationship. The person who's in the relationship with them will always feel as if this person avoids intimacy, avoids connection with them. Now, on the opposite side of that, we have the dependent personality. They usually find the avoidants, the antisocials, the borderline histrionics, and narcissists quite often, if not even the odd eccentric group. Dependent personalities, again, tend to be ones that don't feel a great deal of self-esteem, but they also feel that they need to be taken care of. They need to be taken care of to the extent that they will be in bad relationships because they're so fearful of not being in a relationship at all that they need to depend on somebody else. Then we have obsessive compulsive personality disorder. Now this is not obsessive compulsive person or disorder itself. You got to add the personality in there. So this is not something where they're tapping a wall 6 times or doing something along that time. This obsessive personality disorder has to do with perfectionism. They want to be absolutely perfect. They want their family to be absolutely perfect. It could be that they've seen a commercial about perfect relationships. These have a lot of abuses in them because the towels weren't aligned perfectly. The rules weren't done exactly as they wanted them done. So there's a great deal of problems in that relationship as well. Now we can go to the dramatic ones in the center. These are the ones that you see most often and you will interact with most often, even though you don't even recognize that it's there. The first one is antisocial personality disorder, and that's our psychopaths and sociopaths. Now, many people believe that psychopaths and sociopaths have to be the serial killers that are out there. They do not. Most of the population of our psychopaths and sociopaths have never actually killed anyone. They tend to be CEOs of companies where they can harm others, fire others, not pay others, and get away with it. They tend to be people that work in banks, the loan people that work in banks and then foreclose on people, and they find joy in that. It doesn't really bother them at all that that's taking place. They tend to be in relationships, again, where there's no give and take. It's all about them. But they're very good at making other people believe that they're the nicest person on earth. Now, antisocial personality disorder, we can have women in it, but it's most often men. And so he will, make you believe that they're the most important person in the world, best relationship you've ever been at. And if you get into a relationship where later on you feel like you wish you could get back to the way it was, you're more than likely in a relationship with an antisocial personality disorder. They lie all the time, and many times they lie about things that aren't even worthy of lying about, but they just like to do the deceit, and they love to manipulate others. They can make you feel bad for something that they're doing and make you firmly believe it. I get many people that say, oh, I'd be able to recognize them, and you just can't. You just can't. Borderline personality disorder tends to be more female-based than males. Again, we can have males in it, but it tends to be more often females. Now, when you get into the larger family groups that go to reunions, and there's that aunt or whomever that always has to be not only the center of attention, but tends to love to get everybody else going. They always say they hate chaos, but yet they create chaos. They love to get Uncle Joe mad at Aunt Sue. They love to get the two of them fighting. Now, the main reason is borderline personality disorders are fearful of abandonment. They have such a huge fear of it that they believe, and they will create this chaos to make sure everyone keeps coming back to them. Now, many people will say, yeah, I know they lie. I know that they're not telling the truth. But yet they talk to them. They interact with them. They listen to them. And when they leave, they all of a sudden have this feeling that, oh, I didn't know so-and-so didn't like me, or I didn't know so-and-so was mad at me. They're probably not. This is just something that this person creates so that you'll keep coming back to them for the scoop on what's going on, and you'll keep interacting with them, and therefore they don't feel abandoned. So does the other person. And this is how they create this process of not being left by creating chaos with everybody else. The problem is that it is self-destructive. People will eventually learn and then just avoid them completely. And that's actually what you need to do when it comes to a borderline personality disorder. Then we have histrionics, and histrionics are mainly females as well. Histrionics are all about being the center of attention. People in drama clubs and all that kind of thing love to act and love to be involved in that, but this is drama beyond that. This is where they have to be the center of attention in drama club, but they have to be the center of attention when you're going out. So when you're with your friends and you have a story about breaking your arm, and they have a story that they broke their arm but it was way worse than yours, and then somebody else says, oh my God, I slept wrong and I got a back pain, and they're like, yeah, but mine's way worse than yours. And even if it's your birthday and your birthday party, all of a sudden you'll notice that they're the center of attention and not you. That's our histrionics. We do find sex becomes involved quite often with them, where they're overly sexual because they need that attention. They're terrified of that abandonment again. And then we have our narcissists, and narcissists tend to be men as well, and they tend to think that they're more important than what they are. They'll tell you how really great they are, how very, very wonderful they are. They'll give you a lot of reasons why you should admire them and boast about all the things that they can do, and even though they can't do that. Now, there are the extremes that we can go to, and then there are the lower levels where the narcissist just thinks that they're more important in that relationship than you, that it's all about them. Okay? Now, mind you, they will make you believe that they care about you. They will tell you that they're going to do things for you. It just never gets done. If it's not going to help them, it's not going to happen. Now, here's Dennis Rader. He was known as the BTK killer, bind, torture, and kill. Now, here's how manipulative these people can be when it's antisocial personality disorder. He not only interacted and helped to try and find these bodies and whatnot on several occasions, he was the head of his church, one of the main leaders in his church. He ran the Boy Scouts in that area. Everyone knew of him as the most wonderful guy that there was. He kept involving himself in the police and the investigations, and to the point that they had interviewed him several times, and each and every time they're like, no, can't be him, because he can manipulate even those that are told or trained on how to distinguish one from another. These ones are so understanding of other people's personalities, needs, and wants that they can manipulate you to believe that they are wonderful. Now, these are the kind of people that can get into relationships. Yep, he was married. Yep, he had kids. It can be a terroristic relationship, or it can be one where they just know there's something wrong, but they can't quite figure out what it is, and mainly that's because that person that's in the relationship also has a personality disorder, and typically a dependent personality disorder. Now, when it comes to antisocial personality disorder, here's a lot of the things, or some of the symptoms that we can tell you actually occur. Now, we cannot diagnose you with antisocial personality disorder until you're 18 years old. Prior to that, we call it a conduct disorder, but we can see it happening. Now, the reason we call it a conduct disorder prior to the age of 18 is we're still hoping that we can correct the problem because that brain is still developing and still working on it. But after the age of 18, antisocial personality disorder, deceitfulness, lying, irritable on a regular basis, aggressiveness, whether it's seen in public or not. There's aggressiveness there. It can be emotional aggressiveness. It can be physical aggressiveness, disregard for the safety of others, failure to conform. Now, our sociopaths tend to fail to conform, but our psychopaths are brilliant individuals that conform to society's norms, do everything the way society deems. It'll be the one that, the neighbors, they're finding bodies in the basement, and the neighbors are like, I can't believe that. That was the nicest guy on earth. He helped me fix my door and my windows, and he's so genuinely nice. That failure to conform to norms is a failure of norms, whether you see them or not. They do not feel remorse. They can feel remorse for getting caught, but not feel remorse for what has happened or what they do to other people. We do see some impulsivity with our sociopaths more than we do our psychopaths. And sociopaths tend to have a difficulty keeping jobs, dealing with money, but our psychopaths are perfect at that to an extreme. Again, when it comes to children, it's not until the age of 18 that we're going to diagnose them, but how can we potentially see an issue coming up? Are they impulsive when they're young? Are they unconcerned about rewards or consequences? Do they have low anxiety? And I'll show a thing on this next, but low anxiety means that they need more in order to feel the same thing that other people do. So where other people will cry at being insulted, they aren't going to cry when they're young. They need more. You need to actually get into a physical confrontation with them. Child abuse really pushes this into taking over, or neglect can do the same thing. We also find that there's hormone levels that are at issue, and mainly associated with that amygdala and whether stress hormones are being let loose or not. Let's take a look at when we look at people that are criminals and we look at those with antisocial personality disorder, notice where they're linked there. That's how many people that are criminals that have antisocial personality disorder. Notice that most of them are actually ones that have never committed a crime, not criminals at all. They're the ones that you're in relationships with. Now, I also always tell people that these bubbles should be reversed. It should be people with antisocial personality disorder in that bigger bubble. We have way more people with antisocial personality disorder than is mainly recognized because they're not acting out. But we do see it in massive quantities of relationships. Here's that anxiety thing that we're talking about. So when it comes to, this is 13-year-olds, but when it comes to younger people and the adrenaline that gets running, that adrenaline rush that you get from a stressful situation. So let's say someone pulling out on you in front of traffic or in front of you in traffic, and you get that adrenaline rush of, oh my God, I'm going to die. So when we look at these individuals, we find that that adrenaline rush just doesn't happen. So they need to bring it to a higher level. They need to stalk that person that pulled out in front of them. They need to ride on their rear end. They need to pull them over and start screaming at them. They need more adrenaline rush to have the same feeling that a normal person would have. So they'll push it more to an extreme, and that's why we get some more violent outbursts from them.